Hi there, my name is Dr. John Hughes, and this is the Neurobiochemical Cascade in TBI and PTSD, as well as the beneficial effects of oxygen and serotonin in the brain. This is a lecture for the JPNI. It's a virtual conference, October 2020. TBI and PTSD symptomology, Neurobiochemical Cascade in TBI and PTSD, serotonin, TBI, PTSD, high dose oxygen for TBI and PTSD, treating TBI, PTSD with SSRIs, and treating TBI, PTSD with hyperbaric oxygen and serotonin precursors. This is a lecture to basically discuss how to best treat TBI, PTSD. We'll use those diagnoses synonymously in many ways, so you'll see that. Clinical symptoms, if anybody's ever seen a patient with TBI, you'll have headache, oftentimes vertigo, ear ringing, loss of mobility, seizures. Those are mostly the physical symptoms. You'll have cognitively memory decline, memory loss, either short or long-term memory. You'll have confusion, difficulty communicating thoughts, loss of executive function, unable to plan, reason, and problem solve. Tension, anxiety, these are other changes that occur more psychologically, suspiciousness, suicidality, depression, and PTSD goes right along with TBI symptoms. There's mood lability that often occurs, and very, very commonly irritability. PTSD is defined as an anxiety disorder triggered by exposure to a stressful event, so that the patients have exaggerated responses to normal and traumatic related stimuli. And these can lead to very destructive actions, either self-destructive or potentially long-term, destructive activities. Suicide ideation is one of those, hyperarousal, and there's even violence towards other people at times. But ultimately, very similar symptoms to TBI overall, with a very strong emotional component. Are TBI and PTSD related? This box out of the way here. Symptoms of TBI and PTSD overlap. It's really hard to tell. Especially for military veterans, and that's this picture here, what the patient is really suffering with, because almost all of these patients with TBI have some form of PTSD, or vice versa. PTSD and TBI patients show very similar symptoms. So it's hard to tell if it's just PTSD or if it's just TBI. So, and what we see in the brain is there's hippocampal damage in both instances, with even separate, occurrences of the TBI or PTSD. So what we're saying here is that TBI predisposes individuals to PTSD, and I would even say PTSD makes it harder to recover after TBI. So in conclusion, PTSD can occur after TBI, even if there's no recollection or little recollection of the injury. Neurobiochemical cascade in TBI, as well as PTSD. And this is going to be primarily focused on TBI, but like I said, the cognitive and neurobiochemical changes are very similar. What you have initially with a TBI is you're having mechanical stress, you're disrupting cellular membranes, you get neuronal depolarization, firing and release of neurotransmitters, particularly the neurotransmitter glutamate. Glutamate gets increased extracellularly, and you also have an efflux of potassium ions, with calcium ions going intracellular. The cellular membrane has ultimately been disrupted, and that allows what should be on the outside of the cell to go intracellular and cause a lot of problems. Hyperglycolysis is one. You're at a hypermetabolic state. And at this stage, you start getting increased, like I said, cellular calcium 2+ concentrations that inhibits oxidative metabolism. Even though you're in a hyperglycolytic state, you're ultimately blocking the metabolic ability of the cell. energy demands. They're blocked by there must be met by glycolysis, and ultimately you end up with lactate accumulation, especially if there's not enough oxygen around, and decreased ATP. Cellular ultimately enters a metabolic suppression and widespread depression. And so the neurons are just not firing so well. And even ultimately they end up, because of the intracellular calcium, getting destroyed, and they go through apoptosis. And you also have immediate decreases in magnesium as well. It's interesting, you can see all this kind of in a pictorial diagram here. You can see the release of the glutamate, the release of the potassium ions, and ultimately like decrease AT production, hyperglycolysis, a lot of different ions going in and out of the cell where they really shouldn't be. And ultimately you end up with neuronal death, or even neurons that end up in what's called a quiescent state. Ultimately, disruptions in the neurobiochemical cascade ultimately lead to a patient's overall persistent cognitive, emotional, and somatic symptoms. This is not too far of a stretch as we look at what's happening at the metabolic state, or the neurobiochemical state of the cell in TBI, as well as PTSD. And ultimately, if we want to look for further support for this conclusion, is we can pre-treat animals with magnesium and get improved post-traumatic outcomes before we hit them in the head. We give these patients magnesium, and that counters the influx of calcium ions into the cell. And I think that's ultimately what can help prevent some of these traumatic events from being so bad. So serotonin is a pretty unique molecule. Actually, it does look like even some other substances out there exogenously. Some people say it looks like psilocybin if you look at the organic chemistry here, but it plays a big role in PTSD and TBI. Particularly what we are interested in the neurobiochemistry is something called the serotonin transporter protein, SERT. If you look at patients with TBI and PTSD, you'll have decreased SERT immunoreactivity in the neuronal fibers. SERT is decreased as far as the MRA and protein expression, and there's decreased expression in the cerebral cortex. So ultimately, the serotonin is not being transported into these areas, the neurons as well as the brain, the larger brain. And ultimately, this can be the fact that it's not getting across into these brain areas can mean increased depression with TBI and PTSD patients. Rate limiting steps. These are the RAFI nuclei neuron groups, B1 through 9. That is the principal neurons that give rise to actually the serotonergic forebrain protections, and these actually express the rate limiting enzyme for tryptophan hydroxylase 2 for 5-HT. 5-HT is just another way of saying serotonin, by the way. So if those neurons are damaged or challenged, then ultimately you're going to have less serotonin in the brain. 5-HT, aka serotonin, regulates sleep, appetite, pain, and mood. So very indicative of what we're going to see with TBI and PTSD symptoms is directly related to serotonin. For example, also in chronic stress, we're finding less 5-HT as well. Depression, you also see decreased 5-HT transporter, and ultimately with PTSD as well as stress, there's a significant role of serotonin's effects in the brain. But the bottom line here is that lower serotonin is found in patients with chronic stress, depression, and PTSD. If you also look at what happens on a neurotransmitter basis, we'll call this neurotransmitter systems going in post-TBI. What you end up having is increased noradrenaline levels as well as other catecholamines. So these increase in the fight or flight type neurotransmitters, they increase inflammation in the forebrain as well as anxiety-like behavior. And ultimately, long-term, you decrease the serotonin metabolite that's been seen, the 5-IAA in the prefrontal cortex. So there's less serotonin available and more catecholamines. Increased catecholamines, lower serotonin metabolism, ultimately equals a PTSD-like condition, internal anxiety with poor ability for the patient to manage. So the catecholamines are directly responsible for the increased anxiety, and then the serotonin limits that patient's moods, ability to handle stressors and pain. I call this one neurotransmitters going awry post-TBI. You have also a cholinergic excess, which can kind of ultimately lead to these excitatory amino acids, the catecholamine excesses causing more damage. And there's also other monoamino excesses. So we've already talked a little bit about this, but the dopamine goes up, as well as some of the other destructive neurotransmitters. And this ultimately leads to decreased cerebral glucose use and a metabolic crisis. I really like this quote. The brain is in a metabolic crisis with concussion, potassium ion from inside the cell going extracellular, calcium ions going intracellularly, neurotransmitters widely released in a chaotic manner. It takes energy to pump that potassium back and to put the neurotransmitters back on so that the cell can function. This famous neurologist, he said this in 2013. It's really a large basis of how I understand the metabolic crisis and the neurobiochemical cascade that occurs. Ultimately, helping to resolve that metabolic crisis is a large part of the treatment for traumatic brain injuries. It's interesting what else can raise excitatory neurotransmitters and lower serotonin, and the answer to that is altitude. With low oxygen at a higher altitude, for example, you have lower serotonin. At a higher altitude, you actually have higher dopamine. So what does that mean for us on a PTSD, TBI, suicide perspective? Is that if you look at patients who live at high altitudes, they have a much higher case of suicide. And it's interesting, this is a PhD out of the University of Utah named Perry Renshaw. And what we find is that 25% of variation in rates of suicide can directly be attributed to altitude, probably alcohol too, alcohol at altitude. But with lower oxygen, the brain really just doesn't make as much serotonin. So higher altitude, less serotonin, less oxygen at higher altitude. So you're gonna have people that are a little jazzed up on their dopamine, but ultimately not so happy and able to handle stressors as well. If anybody knows anything about Aspen and Highlands Bowl, this is just outside of Highlands Bowl. We were going over here to ski at a really amazing peak called Tonar Peak. Suicides per 1,000 the population are on the rise, of course, especially post-COVID here. But in Colorado, they're actually significantly higher than the average lower altitude levels in the United States. You can see that with this graph. So let's test this out. There's a little study here that says it took 6 healthy participants, 3 female, 3 male. One group breathed 15% oxygen for 15 minutes. And then the other one breathed a mixture of 60% oxygen. This is oxygen air mixture. And then they injected tracers for these patients. So what they did, they looked at PET images afterwards, and before and after each of the oxygen mixtures, they were able to show that there was a higher 50% on average increase in brain serotonin synthesis with the 60% oxygen group, and a much lower serotonin level with the 15% oxygen group. So pretty cool. Just that small amount of time of breathing oxygen. For example, if you ever go to the emergency room, the first thing they do, they give you oxygen, and I think that just relaxes patients and probably starts helping them create a little more serotonin so they can handle the stress of whatever kind of accident or injury or challenge they might have in the ER. Conclusions: serotonin can be increased by oxygen. Increasing blood oxygen increases 5-HT synthesis in the brain. Tryptophan hydroxylase is not saturated with oxygen in the brain, so the take home ultimately is inhaled oxygen over a short period of time increases serotonin. And there's other studies that support that hyperbaric medicine also increases serotonin as well. what is hyperbaric medicine, which is high dose, high pressure oxygen. We'll describe that here. High dose oxygen, it's FDA approved. I think there's 13 so far approved uses for FDA approved uses for perfusing the tissues for conditions, whether it's carbon monoxide poison, radiation, osteonecrosis, or osteomyelitis. So there's a lot of different conditions. However, PTSD and TBI has not yet been approved, but I have feel that might happen down the road. Ultimately, what we're doing is enhancing and speeding up the body's natural healing process with high dose, high pressure oxygen. High pressure oxygen, also known as hyperbaric oxygen. Basic science, a patient breathes 100% oxygen under increased atmospheric pressure, very similar to diving. Usually when you dive, you don't breathe 100% oxygen, so you're getting a little more oxygen concentration as you get into one of these types of chambers. And the patient's head will be in this area that they can see out of, and they're in this otherwise pressurized chamber. It looks pretty fancy, but it's actually very, very simple device in many ways. How does this work? What we know is the solubility of a gas in liquid is directly proportional to partial pressure of the gas above the liquid. So you have in a cylinder, you have gas, and then you press that into a liquid environment, such as the human body, mostly liquid. And the increased atmospheric pressure increases the amount of partial pressure of the gas dissolved in the fluid. So oxygen ends up in the blood plasma, also ends up in the CSF, as well as other lymphatic areas of the body. So here I just described that: blood plasma, cerebrospinal fluid, lymphatic fluid has an increased partial pressure. Patients are treated at 7 to 22 psi, and they end up perfusing those tissues that are damaged, as well as other tissues, at 10 to 15 times normal, and that's at double the atmospheric pressures at 2 ATA. And ultimately, we're bypassing the normal system of the blood, or the oxygen transport through the lungs. Even though the patient is getting most of that oxygen through the lungs, but we're basically able to rapidly increase that. Poor blood flow, poor oxygenation ultimately leads to tissue damage. And you can see this is kind of the diagram. The red blood cells are getting blocked off by tissue damage, which damages capillaries here. The plasma will flow, but the oxygen doesn't get through. When you increase the diffusion of this oxygen and increase the amount of oxygen in the blood, it doesn't always have to be attached to the red blood cells. So oxygen is actually getting perfused even if the red blood cells can't get into the damaged area. And these oxygen molecules can actually stimulate new capillary growth and ultimately create new angiogenesis. We'll usually see that after about 20 to 25 treatments of hyperbaric oxygen at 2 atmospheres. So pretty cool if you look at these little oxygen molecules in the tissues that potentially are damaged. The mechanism of action, what does it do ultimately? And this is generally your patients are running from 20 to 40 to even 60 treatments of hyperbaric oxygen. What we see is over time is increases in collagen synthesis. So you get a fibroblast stimulation, you get oxygen dependent killing of bacteria. So this is how we treat osteomyelitis and other diabetic wounds, for example. Mitochondrial ATP production. So you get improvements in aerobic respiration. So if TBI or PTSD is a metabolic crisis, what we're actually getting is, and it can shut down ATP production, this can restart it and help resolve that metabolic crisis. And ultimately, we're also decreasing lactate production and acidosis. You're decreasing cell death and inflammation, and you're decreasing sort of that overall sort of aggressive immune response. So you're lowering the leukocyte adhesion and degranulation. Even though we do have an immune boosting effect long term, it's not a hyperimmune damaging response. HBOT for TBI, what else are we getting? You're getting increased tissue oxygenation, as we said, new capillary networks, you're restoring the blood supply and increasing neuroplasticity, as well as stem cells in the blood. So what do we see with the potential brain injury? This is a 51-year-old woman who had a mild TBI, and you can see this is the pre up here, and these are the areas that were were less perfused in here in the yellow. And then after the TBI treatment, she had much more perfusion. This is after I believe 40 hyperbaric treatments. Let's throw a rat in here just for fun. Edema is also decreased with the TBI, and this was measured by diffusion-weighted MRIs, DWI. The spatial learning and memory improved with the rat. Cognitive function improves as well, and ultimately we can reduce brain inflammation with hyperbaric oxygen and improve the symptoms of TBI patients long term potentially, but at least short term we know this. HBOT for PTSD and TBI treatment mechanisms. What we're seeing is reduction, as I said, in cell death, apoptosis, as well as decreased inflammatory cytokines. We're upregulating growth factors as well as antioxidants. You can certainly push, for example, hyperbaric oxygen too far and go past the patient's ability to handle the oxidative stress, but with the correct treatments, you can do pretty good. So in similar mechanisms behind treatment of benefits of HBOT and TBI. And so ultimately what we were saying is you can use hyperbaric oxygen for PTSD and TBI together because their symptoms and their treatments are very synonymous. This is just some case studies. I'm going to let you guys look at some of these. We had a 25-year-old male vet with post-concussion symptoms and PTSD. 3 years after the TBI, where he lost consciousness for several minutes, he completed 39 hyperbaric treatments at 1.5 ATA. So it's a lower pressure than what we are using, for example, with diabetic ulcers, for example. And he had improved blood-brain flow, physical exam, post-concussive symptoms, and complete resolution of his PTSD. He returned to work with no issues. Another patient, he ended up he had some blast injuries, getting 40 hyperbaric treatments twice a day, 5 days a week, and significant improvements with hand and motor speed, dexterity, quality of life, post-concussive symptoms, IQ, moods, and reduction ultimately of his suicide ideation. So hyperbaric oxygen produces a significant drop in PTSD symptoms as well as suicide ideation. A few more patients. We took 16 military subjects, males, age 21 to 45, 2 years post-TBI, loss of consciousness, times 2 minutes for most of these, and then 40 hyperbaric treatments, 1.5 ATA for 60 minutes over 30 days, and they all did pretty well. A significant drop in depression, increased quality of life, less suicide ideation. Ultimately, 64% of them decreased or discontinued their medication. So improvements in IQ, all this stuff is seen as a benefit of hyperbaric oxygen. And potentially what hyperbaric oxygen does as far as potentially increasing serotonin and correcting inflammation, edema, and ultimately resolving that metabolic crisis that occurs with TBI. And you can kind of see some more of these increased perfusion areas. Cost of treatments, just so you know for what your taxpayer dollars are when you treat PTSD, even if it's major depression with it. I mean, the patients or the taxpayers are spending anywhere from $5,000 to $16,000 a year. If they have TBI as well, you're spending 27 to, even for severe TBI, 400,000 plus. Whereas for 80 treatments of hyperbaric oxygen, it's very, very reasonable in an outpatient setting at about $16,000. So ultimately, hyperbaric is not only beneficial medically, but it's also a very cost-effective treatment for veterans with TBI and PTSD. So if serotonin is so great and it can help these patients, let's throw in some SSRIs, and see if that helps. So we know that serotonin dysfunction is related to PTSD. If we can give a serotonin like fluoxetine, would that be safe and helpful for these PTSD patients, TBI patients? What we're seeing is they're only modestly effective in reducing the symptoms of severe depression. They can increase the brain's susceptibility to mood disorders, and they ultimately can cause mature neurons to revert to an immature state and what's called neuronal apoptosis. So SSRIs deplete catecholamines and serotonin long-term and ultimately lead to neuronal degeneration and death. And ultimately that can lead to the symptomologies of TBI and PTSD getting worse. And the warnings, the epidemic of suicides among military veterans is most likely due to cocktail antidepressants, none of which are approved for treating TBI. Antidepressants increase the risk of suicidal thinking in short-term studies of major depressive disorder and other psychiatric disorders. Anyone considering the use of any antidepressant must balance this risk with the clinical need. And that's an FDA warning. It's not even me saying this or anybody else. Ultimately, my bottom line conclusion is that SSRIs equals suicide ideation and depression. Do not use those for TBI or PTSD. And if anybody is suspect of their patients having TBI, especially, do not use those drugs at all. This is just a study of fluoxetine on the 5-HT1 receptor. I'm going to just skip through that because we're running a little short on time. But ultimately, the bottom line on this is ultimately that fluoxetine did not alter the 5-HT1 receptor immunoreactivity, and fluoxetine does not increase serotonin levels long-term, even if you're continuing to take it and have risk for TBI and PTSD. So while we might have improvements short-term, it's long-term not the best use. What else can you use? If you can't use a drug, what else can we use? Anybody ever had a big turkey dinner, Thanksgiving's coming up, you feel a little kind of sleepy? Well, that's tryptophan, and the tryptophan actually is one of the best precursors to 5-HTP, also known as serotonin. Tryptophan hydroxylase is the rate-limiting enzyme. So if we increase the amount of bioavailable tryptophan with eating things like turkey or other things, oats, bananas, chocolates, other meats, we can improve the amount of tryptophan in the body. As well as, interesting, a diet with some healthy carbs can also improve tryptophan assimilation. And this is just some dosing. You can certainly go way too high with too much, but even like just basic nutritional requirements include about 5 milligrams per kilogram. Most patients are consuming far more than that, at 4,000 to 5,000 milligrams or 4 to 5 grams. If you get higher doses, such as 70 to 200 milligrams per kilogram, you can have tremor, and this is mostly when you've done it with drugs or with IVs. So I have to be careful, but I've seen very little danger with tryptophan. It's been taken as a supplement for 50 years. And of course, you can result in serotonin, but usually that's when tryptophan is combined with SSRIs. So if a patient is on an SSRI, don't give them tryptophan until they've weaned off that drug. The supplement dosage should be individualized for each patient. Oral tryptophan can increase serotonin. Variations can be found, but 5-HT synthesis falls in the brain. Tryptophan decreases. And it's interesting, tryptophan does share, it's part of a large group of amino acids that share a competitive transporter. So sometimes when you mix other proteins with tryptophan, it doesn't get as well absorbed. So that's another concern. So be careful with getting too much, and that's why sometimes the carbs actually help the tryptophan get better absorbed. It's interesting, 90% of the body's serotonin is made in the digestive tract, and so having enough beneficial microbes can actually, healthy gut microbiome can lead to increased serotonin levels. They've done studies on this. Probiotics can help depressive patients. Even this is a big meta-analysis, so lactobacillus in particular increases the expression of SERT, and you also show that long-term clinically you're getting lower depression and lower psychological stress. In conclusion, TBI can be the cause of or exist concurrently with PTSD. TBI and PTSD symptoms are almost identical, so therefore the treatment should be very similar. Neurobiochemical cascade is directly related to the post-concussive symptoms experienced by the patient. Treating the patient's neurobiology, including ATP deficiencies, electrolytes, and neurotransmitters, is essential for recovery. Hyperbaric oxygen is a drug that can treat low oxygen diseases or injuries such as those caused by TBI or PTSD. And this can be done scientifically and effectively, cost effectively. Serotonin levels decrease with PTSD, TBI, depression, chronic stress. Restoring those levels is a key component to treating TBI and PTSD. Hyperbaric oxygen, as well as inhaled oxygen, can also increase serotonin. Do not treat TBI or PTSD patients with SSRIs. It ultimately is not a long-term solution. Serotonin can be increased and can lead to more suicide. Serotonin can be increased by oral tryptophan intake, IV tryptophan, by improving the gut microbiome with probiotics as necessary. Thanks very much. Really a pleasure to do this talk again, and really a pleasure overall to share. Thank you.